Hi everyone, welcome to Hub Bites. I'm Sanil Rege, consultant psychiatrist. If you're new to this channel, we cover all things psychiatry and mental health related. So if you're interested in mental health and psychiatry, don't forget to subscribe to our channel. What I've thought about doing the coming year through the series of videos that we want to produce, we're thinking of covering a number of psychiatry concepts. What are those particular concepts? How are they diagnosed and how they're treated? So if you're looking forward to learning more about mental health disorders and psychiatry, then don't forget to subscribe to our channel. And a big shout out to all the subscribers to date. I hope that you've been finding our topics useful, and don't forget to let us know what additional topics you'd like for future videos. So today what we're going to be focusing on is post-traumatic stress disorder. So without further ado, let's jump into what is post-traumatic stress disorder. Post-traumatic stress disorder is a mental health condition that's triggered by a terrifying event. Now, as part of the diagnostic criteria, we'll see later that the specific event is defined, and it has to be a serious traumatic event, either experiencing it or witnessing it. So it can be vicarious or the individual has actually experienced it. Now, symptoms may include flashbacks, nightmares, and severe anxiety, what's called hyperarousal, as well as uncontrollable thoughts about the event. These are these intrusive memories. Now, people with post-traumatic stress disorder may feel intense fear. They may feel that their world has fallen apart, that everything is black, and that nothing makes sense. Worse still, they can often lose hope or the belief that they can recover and lead a worthwhile life. Now, one of the things I find in clinical practice is post-traumatic stress disorder is very, very comorbid. What that means is post-traumatic stress disorder doesn't always just occur on its own, just as a nice category, post-traumatic stress disorder. It often can present along with depressive symptoms, so depression, bipolar disorder, sometimes substance use as a way of coping, and of course anxiety disorders as well. So for most, the trauma is acute and transient and results in minimal functional impairment. So this is really important. In psychiatry, individuals can experience a stressful event or a traumatic event. Doesn't mean that every single person will develop post-traumatic stress disorder. There are certain vulnerabilities that can lead to the development of a disorder. And disorder essentially means the symptoms, the syndrome has impacted significantly on their occupational function, studying, for example, vocation, their relationships, their social interaction, etc. So that's calling it a disorder. Now, the psychological trauma can be classified into three main clusters, and this is how we think about diagnosing post-traumatic stress disorder. The first one is re-experiencing symptoms, and this can happen in the form of flashbacks or nightmares or intrusive thoughts. It can be due to hyperarousal, which is the insomnia, agitation, irritability, impulsivity, and anger. Or it can be avoidance, the third one, which is numbing, withdrawal, confusion, dissociation, and depression. Some individuals have greater vulnerabilities to developing post-traumatic stress disorder. So let's look at what are these particular risk factors. The first one is experiencing intense or long-lasting trauma. Now, one of the important things is when we think about this intense or long-lasting trauma, sometimes it can be a single event, but there is a disorder known as complex post-traumatic stress disorder, which we'll cover in a separate video, where there can be repeated traumas over an extended period, possibly beginning from childhood. And these individuals can also have very similar symptoms as we described, which is re-experiencing the trauma, the hyperarousal, and the avoidance phenomenon. The other risk factor is having experienced a traumatic experience early in life, such as childhood abuse. Having a job that increases your risk of being exposed to traumatic events. Military personnel, first responders, paramedics, etc. Having other mental health problems such as anxiety or depression. Having problems with substance misuse such as excessive drinking or drug use. Now, of course, this can be comorbid. We often see this in clinical practice. Individuals that have post-traumatic stress disorder will often have comorbid substance use as a way of coping, self-medication hypothesis we call it, or affect regulation hypothesis. Lacking a good support system of family and friends, poor psychosocial support. Genetics, having blood relatives with mental health issues, including anxiety or depression. Now, these are vulnerability factors. It's really important to understand that just because someone has this and experiences a traumatic event, it's not about them being guaranteed to develop it. There is a lot of resilience overall in human beings, neuroplasticity, the brain changes, etc., that can be protective. But of course, for some individuals, that vulnerability, that sort of bridge may break due to the number of stresses. And it's really, really important that vulnerability does not equate to weakness in any way. And this is one of the things that we need to recognize, to combat, to destigmatize mental health issues. So let's look at how is post-traumatic stress disorder diagnosed. If you're looking to learn more about this topic and discover a range of other stimulating psychiatry courses, then don't forget to subscribe to the Academy by PsychScene. To diagnose a post-traumatic stress disorder as a psychiatrist, firstly, as in any psychiatric disorders, it's really important that we rule out organic disorders or medical problems. So a range of things can be present. Now imagine an individual that might have had a traumatic event such as a car crash, and they're having all the symptoms of post-traumatic stress disorder, but we forget to examine or rule out a head injury. Now that can influence treatment significantly. Therefore, it would be important to carry out a neurological examination, an MRI if necessary, to make sure that there isn't an actual medical problem that is leading or worsening some of these symptoms. Of course, we do other things such as nutritional deficiencies, iron deficiencies. We're looking at thyroid problems because all of these little vulnerabilities can increase the risk of a psychiatric disorder. So we want to treat it. The other aspect we carry out is a psychological or psychiatric evaluation that includes a discussion of the signs and symptoms. We focus on the event and also the events that led up to developing these particular symptoms. And then we rely on either the ICD-10 or the DSM-5, which is the Diagnostic and Statistical Manual of Mental Disorders. Now, the most important thing here is that these are checklists, but there is a cautionary statement in the DSM-5 that clearly says that it is not meant to be used as a checklist. So what's really important is that we actually use clinical judgment, pattern recognition to provide the patient with a diagnostic formulation rather than just a label, a diagnostic formulation through which we can actually implement a management plan. So what are the DSM criteria for PTSD? The first one, as you can see here, is exposure to actual or threatened death, serious injury or sexual violence in one or more of the following ways. Now, it can be due to either directly experiencing the traumatic event, which is witnessing in person the events as it occurred to others, or learning that the traumatic event occurred to a close family member or a close friend. Now, it can also be experiencing repeated or extreme exposure to aversive details of the traumatic event, such as first responders collecting remains or police officers. So for example, in my clinical practice, patient who was a law clerk, for example, repeated exposure to a number of really traumatic details from a legal perspective. Of course, I don't need to go into those details, but that led to the development of post-traumatic stress disorders, and this individual did have vulnerabilities. Presence of intrusion symptoms. Now, these are the intrusive aspects that I talked about, either in the form of memories, thoughts. Sometimes they can be dissociative reactions. These are called the flashbacks. And the question that we often ask is, do you find that the traumatic event is playing in front of your eyes like a movie? And that's how sometimes people describe it. Intense physiological or psychological distress. Then we have avoidance. So individuals will often avoid places that remind them of trauma, or the traumatic reminders as we call it. Then negative alterations in cognitions and mood. Cognitions is really memories, but also executive function, planning, sequencing, multitasking, doing the things that we do in day-to-day life. And this can manifest as inability to recall, an important aspect of the trauma, markedly diminished interest or participation in significant activities, and feeling of detachment from others. So this is really important when individuals have experienced trauma, that cognitive aspects may be affected. And then we have what's called the marked alterations in arousal and reactivity. So the hyperarousal symptoms that they have. So as you can see, difficulty falling asleep, for example, reckless, destructive behavior, irritability, difficulty concentrating, racing thoughts, exaggerated startle response. So individuals get startled with loud noises, for example. So this is the DSM criteria, but as I mentioned, it's not just about a checklist. Yes, we need these criteria, and many individuals do have this, and that's when we can say that the individual has most likely a post-traumatic stress stress disorder. That's the diagnosis. Now, how is it treated? Now, what's really important here in post-traumatic stress disorder is what we call phase-oriented therapy. And what that means is just because an individual's experienced a trauma doesn't mean that they need to go to trauma therapy immediately. In fact, the phase-oriented therapy means that we need to think about what phase the individual is in. If they're in the acute phase where they have really strong emotional arousal, for example, heightened reactivity, racing thoughts, insomnia, heightened anxiety, mood swings, irritability, etc., etc., then we know that the cognitive aspect, the front part of the brain, may be struggling. If we refer patients during that phase, the acute phase, to trauma-related therapy, then they can actually worsen. Why? Because we need the frontal lobe to be able to inhibit these memories, inhibit these heightened reactions. So the frontal lobe needs to be functioning really, really well for the individual to engage in that therapy. So it's really important that the therapy be carried out at the right phase. If it's done incorrectly, and this is evidence-based, absolutely evidence-based, it's called phase-oriented therapy. So in the acute phase, the focus should be on symptomatic management, relieving distress, helping the patient cope better. Could be lifestyle strategies, sleep hygiene, providing some relief for symptoms either with medication or psychology, and containment, which means risk management, ensuring that the patient's safe. One can provide basic supportive strategies. Now, debriefing is contraindicated. Debriefing worsens the situation. So debriefing of the event is not helpful, and that's evidence-based as well. So it becomes important then to move the patient towards more adaptive coping strategies. And once the patient's symptoms have been contained, that's when the patient can be asked if they wish to engage in trauma therapy. Many times, patient says, I'm doing well. I'm not feeling depressed. I'm able to go to work. I'm able to do all these things. I don't think I really want to touch on trauma now. So I might think about it later, but not now. And that happens quite a lot. And that's why in the late phases, it's really important to ask whether a patient wants to engage in therapy or not. So what are the range of psychotherapies that are evidence-based? As you can see, from a trauma-focused therapy, we have prolonged exposure therapy, we have cognitive processing therapy, we have narrative exposure therapy, and EMDR, which is the eye movement desensitization and reprocessing. Now, this is based on the principle that bilateral sort of tapping or rhythmic movements, bilateral, and the processing of trauma, when combined together, helps integrate the cognitive and the emotional components. So that's why eye movements might be carried out whilst the individuals are talking about the trauma, so that processing is happening. But sometimes individuals do what's called tapping therapy, so kind of tapping on their knees as they're talking about the trauma. Now, there is some controversy around it, but is it evidence-based? Yes, it's evidence-based, and not for everyone, but does tend to work for many patients. Now, of course, there are a range of other therapies that people talk about, brain spotting, etc. But from an evidence-based perspective, this is essentially what are the range of evidence-based therapies for post-traumatic stress disorder. Now, non-trauma focused therapy, as I mentioned, this can be very helpful in the initial stages. Supportive therapy, non-directive counseling, mindfulness and patient-centered therapy, interpersonal therapy, and yoga and mindfulness training. So it's not one size fits all. It's really about individualizing the treatment for the patient. Then we have pharmacotherapy, and as you can see, there's a range of pharmacotherapeutic options. And the reason is because in post-traumatic stress disorder, we need to break the disorder down and understand what symptoms the patient's having. Some patients might have predominant depression and underlying post-traumatic stress disorder symptoms, in which case treating the depression becomes important, and we know many antidepressants also treat the post-traumatic stress disorder. So we have antidepressants, we have antipsychotic medications. Antipsychotic medications are often used to reduce the agitation. Sometimes a significant amount of paranoia might develop, in which case antipsychotic medications are needed. We have anticonvulsants, which mainly act as mood stabilizers. Sometimes individuals have very strong smells, for example, dissociative reactions that can be really evidence of this almost like a mild seizure type aspect in the emotional area in the brain, rather than the motor area where we can actually see seizures. Then we have anti-adrenergic drugs. So we've covered a video on this, clonidine, prazosin, which can be extremely useful in treating hyperarousal, assist with sleep and treating nightmares. So do have a look at that video on alpha-1 and alpha-2 antagonist medications. Then experimental treatments. So these are not mainstream, but as you can see, there are quite a few: D-cycloserine, endocannabinoids, neuropeptides, psychedelics have been talked about for PTSD with some preliminary evidence as well: ketamine, mifepristone, and hydrocortisone. Now, of course, whenever we talk about medication and treatments, this is not medical advice. It's general, it's for education, and it should be discussed with your doctor because every individual reacts differently. The brain's a really, really complex organ, and we need to get a better understanding of the individual in front of us, discuss it, therapeutic relationship, and through that discussion, implement the plan accordingly. Thanks very, very much for watching, and I hope that you found this video useful. Don't forget to leave us a like and of course subscribe to our channel. I look forward to seeing you in another edition of Hub Bites. Take care and stay safe. See you soon. Bye-bye. Synthesizing complex material in psychiatry to simplify your practice.